So, wishing everyone a good evening from India and a warm welcome for this week's Fireside Chat. It's my pleasure to introduce Dr. Abhijit Konnur, who is a consultant nephrologist at the Muljibhai Patel Urological Hospital in Nadiad, Gujarat. Dr. Abhijit is well traveled from the time he completed his MBBS at the Calicut Medical College in Kerala and then completed his MD in medicine at the Baroda Medical College in Gujarat. Thereafter, he served as an assistant professor in the Department of Medicine at the Medical College and Sir Sayyaji Rao General Hospital in Baroda. He then went on to complete his diploma at National Board in Nephrology at the Muljibhai Patel Urological Hospital in 2009, and then served as a consultant nephrologist at Columbia Asia Hospital and Fortis Memorial Research Institute till 2014, where he had also masterminded and set up world-class hemodialysis centers. He then pursued a fellowship in adult nephrology and renal transplant at the University Health Network, University of Toronto, Canada. And upon completion and his return to India in 2016, he's been working with Muljibhai Patel Urological Hospital till date. Along with being an experienced and well-read consultant, Dr. Abhijit has 16 publications in international and local journals such as CJSID, Saudi Journal, and Indian Journal of Transplantation. And he's also contributed to a chapter each in 3 nephrology textbooks. For me personally, over the last year, over the course of my fellowship, he has been an inspiring mentor, an encouraging teacher, and a very dear friend. With that said, I would like to request Dr. Makwabe to extend a warm welcome to Dr. Abhijit Konnur for tonight's presentation. Dr. Makwabe.
Thank you, Dr. Amar, for very good presentations. Dr. Abhijit, you're warmly welcome into today's nephrology webinar and teaching. Dr. Abhijit? Dr. Abhijit,
Yes,
are you there? Yes.
Yes.
My name is.
Thank you,
Yeah,
Dr. Makwabe.
Yes.
Thank you.
My name is Dr. Gina Makwabe. I'm the consultant nephrologist working here in Tanzania, and I'm the medical director at Africa Healthcare Network here in Dar es Salaam. So we are actually so excited when we heard that you are joining us, and we are all happy and waiting to hear you. The audience, nephrologists from Tanzania, and Uganda, Rwanda, and all of East Africa, and also the MDs who are interested in nephrology and who are working in different dialysis centers. So we are actually very happy to have you here today, and we are ready to get an experience and learn from you. You are warmly welcome. Please proceed with our presentation.
Okay, thank you, Dr. Makwabe. And at the outset, let me thank the Africa Health Network, Dr. Lloyd, Nick Pereira, and my young and enterprising doctor here, Dr. Amar Swali, for giving me this opportunity. And I acknowledge the importance of technology where we are able to speak to each other, and I'm able to present to you this very interesting topic of approach to glomerulonephritis across the 7 Cs. I will try to go slow so that we understand the concepts, and this presentation is directed towards a host of audience, nephrologists, internists, and even general practitioners. I'll take a few questions towards the end. So without much ado, let me start. And this is the first slide and probably the most important slide of this presentation. This actually shows the glomerulus. It is a convoluted ball of vessels, and which are covered by very specialized epithelial cells that you see in the red color, which interdigitate with each other. And you can see peeping through that is this red blood corpuscles. Around the glomerulus, we have the urinary space where the urine actually collects and then is shifted into the urinary tubule. So if we cut through the glomerulus, this is the cut section, which actually shows the capillaries with the endothelial cells, which are covered by the specialized epithelial cells called podocytes. And between the two, we have the glomerular basement membrane. And you have these slits between, which are called the fenestration slits, which allow for the filtration of the toxins into the urine. And this whole ball is stuck together by the mesangial cells and the surrounding structures called mesangial matrix, which acts as a cementing material. Let's start by seeing these two cases. One is a 24-year-old female who presents with rashes over her cheeks, symmetrical, small appendicular joint polyarthritis, and painless oral ulcers, decreased urine output. There's presence of hypertension, cola-colored urine, and a puffy face can be seen. Her urine shows subnephrotic range proteinuria, dysmorphic RBCs, and RBC casts. And on the other side, we have a 4-year-old male who presents with a very sudden onset of puffy face and pedal edema, decreased urine output. Now he's normotensive and has foamy urine. There is anasarca present, and the urine shows nephrotic range proteinuria. Clearly, these two people have renal disease, but of very different morphology. So today we will be studying this part, that is the nephritic part of glomerular disease, which involves a host of diseases, which may include IgA nephropathy, post-infectious GN, anti-GBM disease, and a few more. So if we consider the syndromes of glomerular disease, it can be isolated hematuria, where you have disease of the basement membrane, and have isolated proteinuria, which are functional diseases of protein uh, uptake, acute glomerulonephritis, which is essentially inflammation of the glomerular structures, nephrotic syndrome, which is podocyte-associated disease, and thrombotic microangiopathy, which can present due to vascular disease. So when we consider nephritic syndrome, it essentially means somebody who presents with decreased urine output, hypertension, puffiness of face and pedal edema, cola-colored urine, which denotes hematuria, RBC casts, and a urine protein, which is typically less than 3 grams per day. And the other, which we need to differentiate it, is nephrotic syndrome, which usually presents with a urine protein of more than 3.5 grams per day. And these people have decreased albumin in their serum, and because of which they present with puffy face and pedal edema, typically complaining of foamy urine, but their urine usually has no active sediments. And ancillary finding is hypercholesterolemia. So before we go on to clinical vignettes, let's study something about acute glomerulonephritis. So pathophysiology essentially deals with how does it occur? This is where inflammatory cells flood the glomerulus, either through the capillaries, where you have external cells like the neutrophils, lymphocytes, and plasma cell, which come rushing into the glomerulus, or you have cells which are inherent or present in the glomerulus, which starts proliferating, like the mesangial cells, the visceral epithelial cells, or even the glomerular basement membrane, which increases. Let's now deal with the pathogenesis. Why does this glomerular disease occur? Usually it is immune mediated, meaning these cells cause inflammation in the glomerulus. Now the immune complex can the complement system, and this leads to cytokine release. There is involvement of the neutrophils and macrophages, which get recruited and they come rushing in to cause inflammation and also activate the coagulation system. So why is it important to know where these depositions occur? If the deposition of the immune complexes occur below the epithelial cells, usually one sees less of inflammation, but then the podocytes get damaged, and usually this manifests clinically as proteinuria. If there is subendothelial deposition of the immune deposit, it leads to more inflammation and cellular proliferation. It leads to vascular damage and usually presents clinically as hematuria. And if the immune deposits are in the basement membrane, then usually there is a combination of both of these processes occurring. Sometimes the pathogenesis of glomerular disease or glomerulonephritis can be non-immune mediated, where the epithelial cell injury occurs because of toxins, cytokines, some unknown factors which we don't know, which essentially lead to loss of food processes and proteinuria. How does the glomerular respond to this injury? So usually there is increased cells that are seen either from external sources or in the glomerulus itself. And you have proliferation of epithelial cells or crescent formation, which we'll come to later on. There is increased deposition of matrix or connective tissue, leading to hyaline deposition that you can see on histology, which is essentially meaning a deposition of plasma protein, mesangial matrix, and eventually this whole process leads to fibrosis and death of the glomerulus. There is increased deposition of basement membrane material, which leads to thickened capillary loops and increased size of basement membrane on histology. Now, something about how do pathologists approach glomerular disease? The first question is, how many of the glomeruli in the biopsy bit are involved? If it is focal, only some are involved. But majority of glomeruli involved means there's a diffuse process. The second is, how much of a single glomerulus is involved? If only a small part of the glomerulus is involved, it is called a segmental. And if the entire glomerulus is involved, it is termed global. And third is whether the exact cause of this injury is only limited to the kidney or it is a part of systemic disease. So let us go on to the clinical approach to glomerulonephritis. The first step is to make up our own mind about what clinical syndrome are we dealing with. And these are the 4 tools we have to help us in final diagnosis. First step is to do a urinalysis. A simple dipstick will tell us what are we dealing with. If there is presence of proteinuria and not necessarily glomerular range, and we have presence of RBCs, and the microscopy shows dysmorphic RBCs or RBC casts, it aids in the diagnosis of glomerulonephritis. The second is some aids to help us deal why did this glomerulonephritis occur. So looking at serum complement levels, that is C3, C4, and CH50, gives us a clue about which complement pathway is involved. As we all know, C3 deals with the alternate complement pathway, and the C4 deals with the classical complement pathway. And CH50 actually deals with the common complement pathway. The ANA profile, ANCA test, Anti-GBM, phospholipase 2 receptor antibody levels, and factor H antibody levels actually point out to us what could be the etiological cause for glomerulonephritis, which we'll come to later on. And the third and most important step, I think, is a renal biopsy, where we focus our attention on the light microscopy, the immunofluorescence, some special stains required, and if available, electron microscopy to aid our diagnosis. And recently, the onset of newer diagnostic techniques like genetic testing help us in delineating rare syndromes like Alport's or atypical hemolytic uremic syndrome. The classification of glomerulonephritis can be from various dimensions and facets. One is it because of the nephritic syndrome or the nephrotic syndrome? This is a clinical presentation. A histological diagnosis would be whether this presents as proliferative or non-proliferative glomerulonephritis. Third is if depending on the immune complexes that we get on immunofluorescence, whether there are immune complex mediated or non-immune complex mediated, also known as posse-immune. Another is the effect on the glomerulus, that is the presence of crescents or absence of crescents. And of course, whether there is the proliferation of cells is endocapillary or extracapillary. If one goes for etiological diagnosis of nephritic syndromes, the usual causes are for primary nephritic syndrome, post-infectious or diffuse proliferative glomerulonephritis, membranoproliferative glomerulonephritis, IgA nephropathy, and crescentic glomerulonephritis. These could also be because of systemic diseases which involve the glomerulus and hence called as secondary nephritic syndrome, like Henoch-Schönlein purpura, systemic vasculitis, systemic lupus erythematosus, and systemic sclerosis. Just to enumerate some of the usual causes for primary glomerular diseases are disease, membranous nephropathy, and focal segmental glomerulosclerosis. And some of the secondary causes, which are very important to all of us, both in Africa and in India, is diabetes mellitus, which is the commonest cause of nephrotic syndrome in the world today. Other being amyloid and rarely lupus. So as I mentioned earlier, glomerulonephritis is a clinical syndromic diagnosis characterized by hypertension, oliguria, proteinuria, hematuria, which can be microscopic or macroscopic, dysmorphic RBCs in the urine, and RBC casts in the urine. I may draw your attention to the slide number 9, which shows acanthocytes. These are the classical dysmorphic RBCs that are described, and they present as classically described as Mickey Mouse ears. The dysmorphic RBCs typically require phase contrast microscopy, and this is where friendship with the pathologist becomes very important for all of us. There are various other dysmorphic RBCs that have been described, which you can see on the right-hand side of this slide. A microscopy of the urine gives us the clue for the second pathognomonic feature of glomerulonephritis, that is presence of RBC casts. When blood originates from the glomeruli, the RBC pass through the fenestration slits and slip into the tubular lumen, where they are subjected to changes as osmolality, ionic strength, pH, and other forces, and they go and embed themselves on the Tam-Horsfall protein, giving rise to this classical imprint called RBC casts. Acute glomerulonephritis is a clinical diagnosis where the illness is of a few days, usually presents with oliguria, edema, hypertension, presence of hematuria and RBC casts, and proteinuria is typically less than 3 grams per day, so non-nephrotic range. Whereas chronic glomerulonephritis is a diagnosis for illness which are of usually more than 3 months duration, usually involve hypertension, present with renal dysfunction, proteinuria may be more than 3 grams per day. And on ultrasound, usually one has shrunk smooth kidneys to see. And the third finding is of rapidly proliferative glomerulonephritis. This typically presents over days to weeks. This is not associated with hypertension. There is presence of systemic signs. How do you differentiate between urological causes of hematuria and nephrological causes of hematuria? So usually urological causes of hematuria present as with pain. They are bright red. One would usually get serpiginous clots that one can see in the urine. There will be absence of hypertension, and usually they present with voiding symptoms. Typically, in urological causes of hematuria that arise from the ureter, bladder, or even below, one will have, or even an RCC, the renal functions are typically normal, and there is usually no fever or rash that one sees. Now, this is a slightly complicated slide, but it is important for all of us nephrologists to understand the role that complement system plays in nephritis. So classical pathway, as I said, involves a depression of both C3, C4 complement levels in the blood and also CH50. This is typically seen in glomerulonephritis associated with lupus, cryoglobulinemia, and membranoproliferative glomerulonephritis. The alternative pathway typically presents with depressed C3, but normal C4 and a depressed CH50. This is classically seen in glomerulonephritis associated with C3 nephropathy. Sometimes we do get this also in non-glomerular disease like atheroembolic diseases, shunt nephritis, and also endocarditis. And lastly, as I had mentioned earlier, depression of factor H points us towards presence of atypical HUS or dense deposit disease as the cause of glomerulonephritis. So how does one, as I told you, the biopsy seems to be the most important investigation for glomerular disease. So what does one look out for in a biopsy? So on histology or light microscopy in the glomeruli, one usually focuses on the cells, which cells have increased, whether they are from outside the glomerulus or they form part of the glomerulus, and also presence of fibrosis or thickened basement membrane. Very important is any secondary changes in the tubules or interstitium, because the glomes may be damaged, but the creatinine to rise up is usually because of interstitial fibrosis and tubular atrophy. And long-term prognosis of glomerular disease hangs a large part on interstitial fibrosis and tubular atrophy that one sees. And also presence of associated large vessel disease, which can point to systemic vasculitis. The next part of it is immunofluorescence. The formation of immune complexes with deposition of antibodies in the glomerulus is signified by presence of IgG, IgA, and IgM on either the basement membrane or the mesangium. Now, the pattern of deposition is also very important. A linear pattern of deposition actually points towards the reason of the glomerulonephritis being in the basement membrane itself. Whereas a granular pattern actually suggests that the reason for glomerulonephritis is in the blood, and this is just random deposition of immune complexes in the kidney filter. And the third step is to send for electron microscopy if one has access to it. This delineates some diseases. It shows us change in podocytes, basement membranes, mesangium electron deposits, and presence of immune deposits in various parts. So knowing all of this and looking at this, let's take on a few clinical vignettes, which will help us better understand these processes. The presentation is going to become very colorful from now on. And I will, unfortunately, I don't have a pointer, but I will try to show you some of the important salient features in the biopsies that one could look out for. It has also been brought to my attention that many of us may not have access to biopsies. But if I can take you 40 years before in India, when we set up our nephrology institute, we also did not have any access to pathologists or experts. We developed our own methodology. We did the same kind, biopsies are done using the same processing material that one uses for various other surgical biopsies that are done. So I just need the ability to understand and decipher the message that is coming out of the biopsy. So let's go on for a few cases. First is a 20-year-old female who presents with puffy face spindle edema, progressing to anasarca over a very short period of 4 days. There is decreased urine output, no presence of hematuria or any history of cola-colored urine. She is typically normotensive, but anasarchic. Her urine showed 4+ on dipstick, 18 grams of protein in a day, but no active sediments. There was no complement activity with normal C3 and C4. And considering her young age, ANA was negative. A clinical differential of minimal change, FSGS, and membranous was put for this lady. Now, the reason for putting this as the first few slides, is to understand the morphology that we are going to deal with later on. So in this kidney biopsy specimen, if one looks carefully, the glomerulus appears fairly normal. There are no increased cells. The capillaries are all patent. And let's focus our attention on the tubules. All the tubules are back to back. The tubular cells look healthy, and there are no casts that one can see in them. This is on a higher power, where the capillary loops are very patent, clear, you can see through them. The cells on top of the capillaries are the visceral epithelial cells or podocytes. The ones lying inside the capillary loops are endothelial cells. And those pinkish cells that are in between the capillaries are the mesangial cells. And everything seems to be in order. This is a silver stain. Now, essentially 5 types of stains are used. The hematoloxylin eosin HE stain essentially gives us a morphology of the cells that we deal with. The PAS stain gives you a morphology of the basement membranes and the architecture of the cells. The silver stain that is right on this slide here tells us about the presence of fibrin and immune deposits, if any. The meson trichrome, which will come to later on, is a blue colored stain, which tells us about presence of fibrosis and gives us an idea about eventual outcomes. So this is an electron microscope. The one on the left is of a normal glomerulus. Those tall pillars that you see are essentially the fenestrae caused by podocytes, the foot processes, and the black structure inside the capillary is essentially RBC. And the distance between this is the glomerular basement membrane. And on the right side in the pictograph, one can see that those columns have been converted into humps, or they're completely misshapen. So these are called destroyed foot processes. And this is exactly what occurs in minimal change disease. Because of foot process effacement, proteinuria occurs. And this is what is occurring in this lady. So she was diagnosed to have minimal change disease. And the treatment that was given to her was essentially steroids for 6 to 8 weeks, starting at milligram per kilogram and then tapered down. The second case we have is of a 14-year-old male who gives a history of sore throat 2 weeks ago, presented with puffy face, spindle edema, reduced urine output, and cola-colored urine for the last 3 days, hypertension on clinical exam, a urinalysis of 1.6 grams of protein per day, and he had RBC and casts present on urine. His serology showed elevated ASO titer, and his C3 levels were typically depressed. A biopsy done on this young individual immediately shows that the glomerulus are not normal in this. There are increased number of cells. So we say that this is proliferative glomerulonephritis, because there's proliferation of cells there. But the tubules look okay. They're back to back and they're patent. This is the mesenteric strain, which is blue in color. And this was just to signify the number of cells that have increased in the glomerulus. And if I can take you to a higher power, if one focuses right at the 9 o'clock position, one can see multinucleated bilobed nuclei, which are typical of neutrophils, even at the between the 5 and 6 o'clock position. So those actually presence of neutrophils, those are not cells which are usually seen in the glomerulus, typically suggests presence of very large amount of inflammation and usually suggest proliferative glomerulonephritis. And in this case, it is possibly post-infectious glomerulonephritis. There is deposition of immunoglobulins and deposition of complement C3 on the basement membrane. And EM was also done on this biopsy, which shows typical humps that can be seen just below the podocytes. Those dark humpy structures that one can see just above the basement membrane are called subepithelial deposits, which are very classical of post-infectious glomerulonephritis. And he was treated with salt and water restriction, BP control, typically using diuretics, because the hypertension in post-infectious GN is mostly due to hypervolemia. And it turned out to be a self-limiting disease that it usually is. The third case that I would like to discuss is about a 65-year-old male who presented with an insidious onset swelling all over his body for the last 4 months. He had preserved urine output, no hematuria. He was normotensive, but anasarchic. His urinalysis showed a 24-hour urine protein of 20 grams in a day, but there were no active sediments. So this typically tells us that this is probably a non-proliferative glomerulonephritis. Whenever there is no sediments in the urine, it points more towards a more benign sort of a glomerulonephritis. Serology showed normal complement levels, but his phospholipase A2 levels were elevated. And he presented with this biopsy findings. Now, I would like to draw your attention to the glomerulus and the glomerular basement membrane. This is PASTIN, which actually shows that the basement membrane, if one compares it to the tubular basement membrane, that's how one actually compares it. You can see that the glomerular basement membrane is thickened than the tubular basement membrane, telling us that there has been some problem with the GBM. If you see the number of cells appear normal, and the capillary loops are all patent. Again, here, this is a silver stain. Higher magnification, if you look at glomerular basement membrane, these are the spikes which are characteristic of membranous nephropathy. These are immune deposits in the glomerular basement membrane, and that is why there is increased deposition and expansion of the glomerular basement membrane. And in the meson trichome stain, it helps us to find out immune deposits which typically color red. So if you look carefully, you will see a lot of red splotches on the glomerular basement membrane. The immunofluorescence again shows a deposition of IgG and C3 months, unless people have a large amount of proteinuria, more than 8 grams per day, or one has creatinine which is increased. Usual treatment starts with use of ACE inhibitors and AR blockers. So essentially, one would be modified Ponticelli regimen, which has been there for the last 40 years now. And recently with these trials, the Gemritux trial and the Mentor trial, we also are using rituximab, usually in the dose of 1 gram injection, to be given weekly for 4 weeks. And the effect of this usually lasts for close to 1.5 years for patients. One would use anticoagulation if the serum albumin is usually less than 2 grams per deciliter. The fourth case is of a 16-year-old male who presents with puffy face, pill edema, febrile illness, presence of cola-colored urine, and oliguria for 2 months. He, of note, had hemolytic anemia and thrombocytopenia. His LDH was increased, but his sickling test was negative. He had hepatitis C antibody present in his blood. His complement level showed a depressed C3 with a normal C4 and a depressed CH50 level, meaning that the alternate complement system was activated. So clinically, we can say that this person had a proliferative glomerulonephritis involving probably because of complement dysfunction, and also involving a systemic disease. It's a busy slide, but I just want you to focus on the glomeruli. Clearly, the number of cells is large. Also, the glomerulus, they appear lobulated, the capillaries. And the cells are of multiple origin. Not too many of neutrophils that one can see in those cells. So one can also see that the membrane, the basement membrane is increased. So this is typically a proliferative GN involving increased number of membrane and cells. And I think we are dealing with membranoproliferative glomerulonephritis. And there is deposition of C3 in the glomerulus. EM of this biopsy was sent, and I want you to focus your attention on where the immune deposits are. Typically, they appear as that dark graphite-looking deposits. In the left upper slide, they are typically subendothelial. In the bottom slide, they are throughout the basement membrane. This is classical of dense deposit disease. So a few words about membranoproliferative glomerulonephritis. There has been a rework of the classification for this. Depending on the reason for presence of glomerulonephritis, it could either be due to immune complex mediated. The four things that one would remember is due to presence of chronic infections like hepatitis B and C, autoimmune diseases like lupus, presence of multiple gammopathy of unknown significance or lymphomas, and cryoglobulinemia, which is very rare, but it is usually associated with patients who suffer from hepatitis C. It presents as proliferative glomerulonephritis, typically having subendothelial immune complexes, which are seen on electron microscopy. And it involves the classical pathway of complement dysregulation. The immunofluorescence will present with polyclonal immunoglobulin deposition. In case it is monoclonal immunoglobulins, that is only one pattern, that is IgG or IgM is deposited, then you know that it is probably because of a lymphoma or a MGUS. The other cause for presence of membranoproliferative glomerulonephritis is this rapidly emerging and interesting diseases associated with complement dysfunction. There is usually deposition of C3, but not C4. And the electron microscopy plays a crucial role here. The dense deposit disease typically presents as dense deposits in a linear fashion in the glomerular basement membrane, whereas the C3 glomerular nephropathy presents with deposition in the subepithelial, subendothelial, and mesangial regions, but not usually the glomerular basement membrane. So this is one disease process which requires electron microscopy to differentiate the two. Why is this so important? It's because people who have dense deposit disease tend to have a very high recurrence rate. More than 90% will have a recurrence and graft loss after renal transplantation. Whereas C3 glomerulonephritis is quite amenable to treatment. Overall, the news of membranoproliferative glomerulonephritis is bad for the patient. Nearly 1 in 2 patients lands up on dialysis in a span of few years. And it helps in prognosticating the disease. Okay, we are coming to the fag end. I have total 6 cases. I think all of you must be really tired of seeing too much of color on the screen. So let's rush through 2 of the last 2 cases, which are very interesting and probably the most important because we deal with them on a daily basis. Case 5 is of a 16-year-old male who presents with persistent painless hematuria, bright red, no clots. Important because clots would have said that there is a urological cause. Usual episodes, the mother says, occur soon after sore throat infections. It presented with hypertension, but there was no history of oliguria, no pedal edema. He was having normal hemoglobin, no hemolysis in the peripheral smear. The urinalysis just showed gross hematuria and RBC class and dysmorphic RBCs, clearly telling us that the source was from the glomerulus. His complement levels were normal. His ASO titer was normal. The ultrasound did not show any structural abnormalities of the kidney. The biopsy specimen actually shows that there are increased number of cells in the glomerulus. In the lower part, in the lower slide, one can see that the number of cells that are increased are, if one focuses well, are in the mesangium. The capillary loops look all patent. There are no cells outside the capillary loop. There don't seem to be any cells like the neutrophils or plasma cells which are coming from outside. Most of the cells appear to be largely from mesangial origin. This is another pass stain showing similar structures. And if one looks around the glomerulus, one can see that the tubules are sparse. They are separated from each other. This actually does not augur well for the patient. It shows interstitial edema and sometimes can also be a harbinger of tubular atrophy and interstitial fibrosis. The silver stain actually brings out the increased amount of mesangial matrix that you can see in the mesangium. And the thing that clinches the diagnosis is the immunofluorescence in this slide, where you see IgA deposition very strong as compared to the other that are there in the mesangium. So a diagnosis of IgA nephropathy was kept. Another wording for this is mesangioproliferative glomerulonephritis, usual because of altered IgA types in the blood, which appear sticky due to altered galactose formation on the IgA, usually characterized by episodic hematuria, which follows respiratory tract infections. It can occur in 20 to 60% of transplants, usually is benign, and is the commonest cause of glomerulonephritis in young adults. I just skipped this. And we come to probably one of the most important set of slides now is about a 24-year-old female who presented with rashes over her cheeks, symmetrical small appendicular joint polyarthritis, painless oral ulcers, decreased urine output, hypertension, cola-colored urine, and puffy face. Her urine showed subnephrotic range proteinuria, dysmorphic RBC and RBC casts, clearly pointing out to a proliferative glomerulonephritis of a systemic origin because multiple organs seem to be involved in her case. Her serology showed low C3 levels, and her ANA and the dsDNA titers were elevated, giving us a clue that probably we were dealing with lupus nephritis. The biopsy again shows the glomerulus, which is filled with cells, is full. If one goes closer, one will see that there is a proliferation of cells. And here we can see some classical findings in lupus nephritis in this particular biopsy, which I want to draw your attention to. At the 3 o'clock position, you see the thickened basement membrane, which is irregular. And one can see this kind of thickened basement membrane in other parts of the glomerulus. These are called wire loop lesions. The other is straight bank center. And also at the 4 o'clock position, one can see nuclei which appear smudged. These are classical of choriorrhexis that is occurring in cells in the glomerulus. Also, one can see at the 6 or 7 o'clock position an area of the basement membrane which has no cells but is typically pink in color. This is hyalinization that one can see, or hyaline thrombi formation. And if I can draw your attention to this slide, it's a hematoxin eosin slide. Bang on center, right in the middle, there is a capillary which has something inside, it's pink material, and this is intracapillary fibrin thrombi that have been formed. And you can also see wire loop, appreciate the wire loop lesions that one can see in the basement membranes around in the glomerulus. The silver stain actually accentuates these findings in the glomerulus. And as we all know, the immunofluorescence that clinches the diagnosis is presence of full house immunofluorescence, meaning the light up of IgA, IgG, IgC3, C1q, and also IgM. We don't have it here, but essentially even IgM lighting up tells you a full house match, and presence of C1q in the glomerulus actually is very suggestive of lupus nephritis. So we are dealing with class 4 lupus nephritis here. And as all of us know, there are two popular regimens for treatment of lupus nephritis. One is the NIH protocol, and the second is the Urolupus protocol. The NIH protocol uses conventional high-dose oral prednisone, a milligram per kilogram per day for at least 6 to 8 weeks with gradual tapering, and oral or IV cyclophosphamide, depending on how close or far the patient is and how comfortable we are with the patient. And it can be a high dose or low dose protocol, usually around 2 to 4 milligrams per kilogram per day of cyclophosphamide orally. The Urolupus is more conservative. It uses a dose of around 2 milligrams per kilogram of cyclophosphamide. The cyclophosphamide in the Urolupus protocol is typically IV. In my own hospital, I usually treat patients on a fortnightly injection of IV cyclophosphamide, fixed dose 500 milligrams for 6 to 8 doses, and then switch them over to maintenance regimen of azathioprine. This is probably the last case that we are dealing with, and also quite an interesting case that we had of a 60-year-old male who had no prior comorbidities. He had acute onset puffy face, spittle edema, and decreased urine output. He presented with history of recurrent hemopsis. He was normotensive on exam. His urinalysis showed 2 plus protein on dipstick. There were presence of RBC and RBC casts. The serology showed normal complement levels. The ANA profile was negative for any autoimmune disease, and ANCA titers did not show any elevation. So what were we dealing with here? He promptly underwent a renal biopsy, and this is something that all of us fear to see. This is one of the worst case scenario of glomerular disease, presence of crescents. So crescents are essentially at least 2 layers of cells deposited extracapillary, which one can see here, starting from 2 o'clock position right up till 11 o'clock position. And along with that, there is deposition of protein, which pushes and completely strangulates the glomerular structures inside the glomerulus. This is a hematoxylin eosin stain, actually showing that most of the crescent is cellular in nature. There are cells that are present in the crescents. Similar structure. Importance of finding out whether say crescents are cellular or there is presence of fibrosis. Now this stain is a silver stain. If there was presence of fibrous material, it would have stained dark black, telling us that this process has been going on for a long time, and that the possibility of having a good outcome is very poor in these patients. One would not be very aggressive with use of immunosuppressants in these people and probably prognosticate them that way. Again, meson trichome here again points towards presence of fibrosis. If the staining is dark blue, it suggests that presence of fibrous material. Here one can see that it is very less than 25%. Presence of IgG and C3. Of note, one can see that the immunofluorescent deposition of IgG in this particular glomerulus is linear. It is classically described as ribbon-like. This is very classical of anti-GBM disease. And that's how he got diagnosed. He underwent 14 days of plasmapheresis, also required hemodialysis. We treated him with injection methylprednisone 1 gram for 3 consecutive days, and then switched him over to oral prednisone with a slow taper, and oral cyclophosphamide given at 2 milligrams per kilogram per day. So a couple of slides about Crescentic GN. This forms the category of rapidly progressive glomerulonephritis. They are characterized by glomerular crescents, which are accumulation of cells in the Bowman space, also involving inflammatory cells, fibrin, and epithelial cell proliferation. They compress the glomerulus, and they have a rapidly progressive clinical course. They damage the glomerular vessels, and if the pressure in the Bowman's capsule can be such that it can lead to breakage of the Bowman's capsule and egress of this material into the interstitial space, which is probably the worst case scenario in glomerulonephritis. So a classification, working classification of crescentic GN essentially is if there are immune complexes that one sees on IF, immunofluorescence, then we are dealing with immune complex mediated crescentic GN, typically due to lupus nephritis, post-infectious glomerulonephritis, could be due to IgA nephropathy, or henoch-Schönlein purpura. If there are no immune complexes seen on the immunofluorescence stain, then one is probably dealing with ANCA-associated diseases like GPA, microscopic polyangiitis, or eosinophilic generalized polyangiitis. And if there is linear ribbon-like deposition of IgG on the basement membrane, then one is dealing with good pasture syndrome that we saw, anti-GBM disease. So I think coming to an end to this exhaustive presentation, a few take-home messages from me, from India to my brothers in Africa. Number one is, let's form a syndromic diagnosis when we see a patient in our clinic who we suspect having a glomerular disease. Is it nephrotic or is it nephritic? Is it proliferative? Is it non-proliferative? Is this a part of systemic disease or only the kidneys are involved? Second is to analyze the liquid gold, meaning the urine. A dipstick can help us clinch the diagnosis. Presence of protein and RBCs on the dipstick point to a diagnosis of proliferative glomerulonephritis. After that, it makes sense to send for appropriate serology, depending on what clinical circumstances we suspect. Let us all keep a very low threshold for renal biopsy. It sometimes changes the outlook and the prognostic outcomes for patients. And lastly, to care for all our patients, we must tell them that they need to have patience. Treatments are usually prolonged, and usually we need to take them into confidence so that they can reconcile with their disease. Thank you for very patient hearing.
Wow. Thank you very much, Dr. Abhijit. That was a very comprehensive presentation, very well covered. You covered all the GNs. Now we are going for the questions. Is there any question from the audience? Any question?
Yes, I have a question.
Yes.
Hello, yes, Dr. Makanga from Uganda. First of all, thank you for the comprehensive presentation. It was well done. Thank you so much. But I want to take you back to case number 5.
Thank you.
The lupus nephritis lady. Just your view. There are quite a number of protocols for managing, I think, stage 3, stage 4 lupus nephritis. And I think you emphasize more on the protocol that emphasizes cyclophosphamide and prednisolone. I wanted to find out what your experience is where we may not be able to use cyclophosphamide and want to use MMF or mycophenolate versus cyclophosphamide, especially in these women who, the young ladies who are planning for future families. Thank you.
Right. So, yeah, thanks. I think that's a very interesting question. Now, most of the data for use of mycophenolate mofetil comes from China in Chen's studies. He has used mycophenolate mofetil at 2 grams or 3 grams dose, both as induction and as a maintenance regimen for patients. What you typically pointed out for young ladies who are anxious about losing their fertility to cyclophosphamide. In my own limited experience of using mycophenolate, when compared to a larger experience of using cyclophosphamide, I have found it to be slightly inferior. It does not seem to work very well in the Indian population. I would strongly suggest using cyclophosphamide, especially in class 3, class 4 lupus, especially in patients who may not be able to give a strong follow-up or a close follow-up with the doctor. At the doses at which cyclophosphamide is used, of my own experience, I have seen that most of the times it does not seem to affect the sterility. But yes, patients need to be told that there is an outside chance and they need to use barrier contraceptives when they are on treatment for this.
Okay, thank you, Dr.
Thank you.
Makanga. Yeah. Are you satisfied? Do you have another question?
No, that was it. Thank you so much.
All right.
Like
Thank you,
ask
Dr.
a question,
Makanga. Any other question? Yes, please.
Hello, Dr. Abhijit. My name is Dr. Amir Ali. I'm a recently qualified nephrologist. I just wanted to ask you with regards to the patient, the 65-year-old patient who had membranous nephropathy. I saw his Pla2 antibody was positive, but would you consider the cause of his membranous as a secondary cause, probably from malignancy, given his age and the onset of the membranous nephropathy?
Right. Thank you. Another very interesting question from Dr. Amir Ali. So you are right, Dr. Amir Ali, that elderly patient who presents to us with membranous nephropathy, one would really take pains to rule out secondary causes. I, as a routine, would look out for his lymph nodes, do a chest X-ray to find out any mediastinal widening, do ultrasound abdomen to see any swellings. But of late, I have noticed that doing a serum Pla2R stain clearly points out strongly to primary causes of membranous nephropathy in these patients. So you are right. In the clinic, one would do a limited examination and rule out secondary causes of membranous, take a good history. He's not on any drugs which can cause membranous. But at the same time, it is at least in many centers now easier to send for a phospholipase A2 receptor antibody titer. And if one has access to it, it kind of clinches the diagnosis. Also, it helps us in understanding whether the patient is going to respond to therapy. It has been shown clearly now that people whose titers go down with the onset of therapy are going to respond to the treatment. And somebody whose titer is not going down is not responding appropriately to the therapy.
Thank you for that response. I just want to follow up a question on the same Pla2 antibodies, if it's okay. And the question basically is that you mentioned that the patient, you would watch and wait, which is normally what we do in patients in membranous nephropathies, that we give them ACE inhibitors and see what's going on. But if they don't respond, then we usually then start them on treatment. But do you usually do that for all your patients, or do you use the Pla2 titers to decide if you're going to start, immunosuppressive therapy sooner, say, in 3 months' time or so?
Another interesting question, because membranous nephropathy's got everybody's imagination now. You are right, doctor, that one would actually look out for the clinical syndrome that person is having. If he has a proteinuria more than 8 grams a day, or if he has a creatinine which is more than 2.5 or 3 milligrams per deciliter, these are not good augurs for outcomes in these patients, in which case I will not wait to see if he's going to spontaneously remit. I would probably start him on immunosuppression medication. It can either be the Ponticelli or the rituximab. But yes, treatment is required. If this person comes to me with a proteinuria which is less than 4 grams per day, or his creatinine is normal, and there are no secondary causes of membranous, then I am willing to wait at least for 3 to 4 months to see if he shows any signs of spontaneous remission. At least 25%, 1 in 4 patient is supposed to spontaneously remit in if one waits for up to 6 months.
Thank you so much.
Thank you very much, Dr. Abhijit. A follow-up question on that regarding the modified Ponticelli regimen for the treatment of membranous nephropathy, where you give 6 months corticosteroids alternating with cyclophosphamide. Now, you give prednisolone for high dose of prednisolone for 1 month, and then you stop abruptly. You go to cyclophosphamide for 1 month. Have you ever seen any case with steroid effect, withdrawal effect? The abrupt withdrawal of steroids. Have you ever seen any side effects with that patient?
Okay.
Like
so
with adrenal insufficiency?
Yes.
With adrenal insufficiency, yes.
Right, sir, I get your point. So the KDIGO actually recommends that, for example, if we have a patient with membranous, what I would do is in month 1, I would give him 1 gram of steroid a day for 3 days, and then switch over to oral 0.5 milligrams per kilogram per day for the next 27 days. And then at the end of 30 days, that's on month 2, I will give him either oral cyclophosphamide if he lives close by, or intravenous cyclophosphamide single dose. That's what I do. So I alternate, but at point of time, I keep patients on steroids. In the sense, during the cyclophosphamide regimen, they are not on steroids, but I am yet to see anybody who comes to me with a adrenergic crisis because of a sudden stoppage of steroids. By the time the steroid effect goes away, they are on their next dose of steroids, unfortunately.
Thank you very much. Any other question? We still have like 9 minutes before we end our.
There is this case, 16-year-old, I think he was a young man who had whom he treated for IgA nephropathy. You get me? Hello.
Yes, Dr. Tarindo, please proceed, please. Yes, we can hear you.
Yeah, and now, what effort did he make to exclude henox-conlin glomerulonephritis?
Yeah, so that's a good question, Dr. Rindwa. Basically, henox-conlin purpura, HSP, is a systemic disease, and usually around 2/3 of the patients will present with abdominal symptoms. Either they'll have hematochezia, history of abdominal pain. There would be peripheral signs of purpura that one would get. At least 40% of patients present with purpuric spots. This would point out towards the differentiation between IgA nephropathy and HSP. But yes, in the biopsy itself, it would be very difficult. If somebody just puts a biopsy in front of you, it would be very difficult to differentiate between the two.
Thank you. Yeah.
Yeah, thank you. The second question. I think there's another case you presented. I don't know what case number 4. And this patient who had, presented clinically with what looks like arthritis, and then plus of course nephritis. Do you know? Do you know that case? I don't remember. What case number that was. And in that case, I was also made to think a possible alternative diagnosis of cryoglomerulonemic glomerulonephritis.
Mm-hmm. Doctor, we missed the last part of your question.
I'm saying that case that presented, the case that, I don't remember what case number it was, but this patient presented with features of arthritis and together with glomerulonephritis. And in that case, one cannot help but think also the possibility of cryoglobulinemia, cryoglobulinephritis.
Right. So, Dr. Joseph, the cryoglobulinic glomerulonephritis presents with, yes, it can be a deceptive diagnosis for lupus too, where you have arthritis, you can have skin rashes that occur. Typically, cryoglominic GN is seen either in association with lymphomas, usually seen in elderly people, and usually also seen with people who are afflicted with hepatitis C because of presence of polyclonal immunoglobulin, this thing. So those would be things which should point us in that direction. Usually I have seen my own set of patients I saw of cryoglobulinic GN when I was doing my fellowship in Canada, where people had to be taken off the streets and put in really heated rooms. We were told not to open the door so that there's no cold air that goes in and precipitates attacks of cryoglobulinic GN.
Thank you.
All right. Thank you, Dr. Joseph. Thank you, Dr. Abhijit, for a very good answer. Dr. Lloyd, do you have something to comment?
Dr. Abhijit, great presentation. Thank you very, very much. Just one thing, supposing you have recurrent lupus, recurrent class 4 lupus after therapy, maybe 3-4 years down the road, would you use cyclophosphamide again? And if so, would you sort of consider and modifying the dose? The other thing is, we all practice, in protecting, getting some ova out before therapy or some sperm bank, storage, something like that. Do you all do anything there?
Right. Thank you, Dr. Lloyd. I got two parts of the question that you asked me. One is your point was taken that there is a cumulative toxicity of cyclophosphamide in individuals. So at some point of time, in terms of mycophenolate or azathioprine for maintenance, and cyclophosphamide does have cumulative toxicities, not only on the bladder but also on the bone marrow. So I would be very hesitant to use cyclophosphamide multiply for these patients. And in my own practice, sir, I can proudly tell you that I have sperm banked a couple of males who had lupus with me because they were very concerned about their fertility. With the females, as one of the gentlemen pointed out on the panel, sometimes we are forced to use non-cyclophosphamide means in terms of using mycophenolate. Or of late, there has been some interest in using rituximab also in these people.
Thank you so much, Dr. Abhijit. Thank you.
Yeah.
Thank you, Dr. Lloyd. So we'll go into SMS. We'll answer like few questions. One is, Dr. Abhijit, can you please kindly comment on the approach to treatment of class 5 lupus nephritis? That is from Marie and everyone. Marie, can you please respond to that question?
Yes, doctor. So class 5 lupus nephritis is like the honeymoon lupus nephritis. Usually it has a good prognosis. It does not need loading with a lot of immunosuppression. Typically, it presents as membranous lupus nephritis. There are not too many active cells in the urine, but there is a transient decrease C3. So how I treat these patients essentially is to use low dose steroids and at times mycophenolate meflotil as maintenance for these people. And the treatment can go on up to 2 months, 2 years. And once there is no disease activity, meaning the dsDNA levels are non-existent, the C3 levels are normal, I usually taper these and switch these patients over to hydroxychloroquine therapy. I do keep a watch out to see sometimes these people have this ability of shifting into more noxious classes like class 3 and class 4. It's usually seen when the urine they present with hematuria.
Thank you. I think you have responded well to that question. Because of the time, I would allow only one question from the audience. Now we have come to the end of our presentation today, our webinar. Thank you very much, Dr. Abhijit, for the very comprehensive presentation. You covered almost everything regarding GN. We really appreciate for your time. We know you seized your very important tasks, and then you decided to join us and you shared your experiences. Very good case presentations. We really appreciate for everything. Now we have come to the end of our presentation, and we thank you everyone for coming. You also seized your very important tasks and joined this presentation. And Dr. Abhijit, we would like maybe to thank you again. And if we ask you again to come and have a presentation with us, East Africans, I think we'll be happy to have you again next time.
Absolutely.
On behalf of
pleasure is all mine, and thank you.
Yeah, on behalf of Africa Healthcare Network and Mr. Nick, Dr. Lloyd, and all nephrologists and MDs who participated in this presentation, we really thank you. And that's the end of our presentation. Thank you for coming.
Thank you, Dr. Abhijit. Thank you very much for that elaborate.
Thank you, Dr.